screen. Fantastic. Thank you so much, Stacy, and good afternoon. Welcome to the 8th webinar of 2022, supported by the ACCP IM Immunology and Transplantation PRN, as well as the American Society of Transplant Pharmacy COP. My name is Georgina Walthman. I am a heart and lung transplant pharmacist at the Massachusetts General Hospital, and it's my pleasure to moderate today. Today, our webinar is titled the AST ACCP Collaboration Webinar Debate, CKD and Non-renal Transplants. And we are honored to welcome Dr. Spencer January and Dr. Krista Walter today to be presenting. As a brief introduction, Dr. Spencer January is currently a lung transplant clinical pharmacy specialist at the Barnes Jewish Hospital. She currently works with both the inpatient and outpatient lung transplant population. Dr. Krista Walter is currently a clinical pharmacy specialist at Michigan Medicine, who completed pharmacy school at the University of Michigan and subsequently completed her PGY1 and PGY2 in solid organ transplant at the University of North Carolina. In her current role, she primarily cares for lung transplant recipients. However, in addition to this, she provides ambulatory care services for the adult patients with cystic fibrosis, as well as abdominal transplant recipients. In a moment, I will be turning it over to Dr. Spencer January to begin the presentation. But first, here are a few quick notes. For our audience members, please ensure that your microphone remains muted for the duration of today's presentation. The mute button is located in the lower left-hand corner of your screen. And if at any point during this presentation you have a question for the speaker, please submit your question using the chat functionality at the bottom of your screen. Please send your questions directly to me today for the webinar to minimize possible interruptions. However, I'm pretty sure that one of our questions we're going to ask at the end is going to generate some audience discussion, which we might ask you to unmute for that portion of the presentation. We will take all of our questions and discuss them at the end of the presentation. Today's webinar is being recorded and will be posted on the ACCP IMTR YouTube channel. If you do experience any technical difficulties during the webinar that are not fixed by logging out and refreshing your internet connection, please make sure that, please let me be aware and I will try to help triage that as well. Stacy, if you wouldn't mind sharing the full screen of the slides and moving forward, I think we're still seeing the editing view. Thank you. And here we are seeing the presenter view if you want to swap. And we're still seeing the notes presenter side. Thank you. Sometimes with those double screens, it'll get you. While we're figuring that out, I will also remind you all that we have actually gotten continuing education credit for this presentation. So in order to obtain CE credit, you must complete an electronic evaluation. And after completing the evaluation, you can generate your certificate immediately. This will be done through the Rush University Medical Center, which is jointly accredited by the Accreditation Council for Continuing Medical Education, ACCME, the Accreditation Council for Pharmacy Education, ACPE, and the American Nurses Credentialing Center, ANCC, to provide continuing education for the healthcare team. And this activity has been reviewed and is being presented without bias and without commercial support. So Rush University Medical Center has designated this knowledge-based, application-based, live internet enduring material activity for a maximum of 1 hour of CE credit for pharmacists. Thank you. And the next slide, I'll introduce the learning objectives for this. The learning objectives for this presentation today are to describe the key findings of the pilot randomized controlled trials utilizing de novo belatacept in lung transplant recipients, evaluate if a lung transplant recipient experiencing chronic kidney disease may benefit from belatacept initiation with calcineurin inhibition minimization, describing the use of mammalian target of rapamycin or mTOR inhibitors as a renal sparing strategy after lung transplantation, as well as discussing considerations for initiating an mTOR in a lung transplant recipient with renal dysfunction. And with that, I will turn it over to Dr. Spencer January for disclosures.
All right. I'm going to start with disclosure that we'll be discussing the off-label use of belatacept, everolimus, and sirolimus in this presentation. The outline for the debate format today is going to be starting with the evidence behind using belatacept or mTOR inhibitors for renal sparing protocols. We'll start with the belatacept evidence and then move into the mTOR inhibitor evidence. After that, I will be briefly speaking about the recently published trial with de novo use of belatacept following lung transplant. Then we'll move into adverse effects, starting with belatacept and mTOR, and then ending with mTOR inhibitors. And lastly, we have a couple of patient cases that we'll be discussing whether or not we think that belatacept or mTOR inhibitors would be appropriate for those patients. So I'm going to kick us off with the evidence behind using belatacept in lung transplant for renal sparing. And this is really limited to 2 different case series. The first case series was 9 converters to belatacept. They were converted mainly for PRESS or TMA. And in this case series, belatacept replaced the calcineurin inhibitor. And the average time to conversion was about 3 years. The median follow-up time after conversion before this study results were published was only about 6 months. What they found was that when they compared those patients pre-conversion GFR with their post-conversion GFR at the end of follow-up, there was a significant improvement in their GFR, moving from 32 to 45. The GFR trends by patient is depicted in the graph at the right. They also stated that there was no de novo, DSA, or antibody-mediated rejection episodes following conversion, which is congruent with the kidney transplant literature demonstrating a decreased risk of DSA in belatacept when compared to calcineurin inhibitors. The authors stated that there was no difference in CLAD pre and post, but it should be noted that there was only 6 months of follow-up time, and this is the more long-term outcome. Additionally, when we look at the table of that's stratified by patient, we see 2 patients that actually increased in or advanced in their BOS staging after conversion. And the second case series was in 8 patients that were converted to belatacept. And this was a pretty non-standard conversion protocol that they had. At this institution, when patients had the first sign of CKD following lung transplant, there were a few strategies that were used to try and minimize the calcineurin inhibitor exposure. So they could have had a lower tacrolimus trough goal once they experienced CKD, and that could have been plus or minus the addition of an mTOR inhibitor. Most of the patients after conversion were maintained on the calcineurin inhibitor tacrolimus or their mTOR inhibitor at lower trough or dose levels. So these patients were on quadruple immunosuppression, as opposed to the previous case series where only converters that replaced the calcineurin inhibitor with belatacept were counted. The average time from transplant to conversion was about 2 years. And I do just want to point out that these 8 patients are not really comparable to one another. A couple of them were on cyclosporin coming into the conversion. A couple of them were on inhaled cyclosporin coming into the conversion. And then a few of them also were on mTOR inhibitors coming into the conversion. What they found was they compared it to a historical cohort that stretched all the way back to 1992. And so they do report that they had a significant increase in the GFR after conversion to belatacept, especially when compared to the historical cohort. This is graphically depicted at the right with the historical cohort trend in creatinine in those boxes, and then the trend in creatinine for the belatacept converting patients in the dots. And so we see that the creatinine decreased in both populations, but more so in the belatacept converted patients. However, it should be noted again that these historical controls really went back to 1992, where they generally had higher calcineurin inhibitor trough goals, which could have blunted the creatinine or GFR response. They also reported that they had 2 of the 3 patients on dialysis come off of dialysis after belatacept conversion. And at first glance, this seems really impressive, but one of those patients came off of dialysis 6 days after their first infusion, and then the second one came off of dialysis 13 days after conversion. So those patients coming off of dialysis less than 2 weeks after their first belatacept dose makes me a little hesitant to attribute it all to belatacept. Although it was not the primary outcome of this study, the authors reported that there was stable lung function and that there was less infectious complications in the belatacept-treated patients. Although again, it should be noted that those historical controls really went back to 1992, which likely had a higher overall immunosuppression burden and therefore a higher overall infectious risk, which could have confounded that outcome. And now I'm going to switch it over to Krista to talk about the mTOR inhibitors.
Okay, thank you, Spencer. Let's see if I can control the screen here. Okay, great. So as you all know, there's multiple different roles for mTOR inhibitors in transplant, aside from preventing rejection. They have a lot of different properties that we can often utilize to our advantage when creating a maintenance immunosuppression regimen for a patient. But today I'm going to be focusing on the renal sparing effects of mTOR inhibitors in lung transplant recipients. So there are a variety of different strategies you could use when thinking about a renal sparing strategy. The most common one, and most of the data comes from reduced dose calcineurin inhibitors in combination with an mTOR inhibitor along with an antimetabolite and steroids. This would be sort of a calcineurin inhibitor minimization strategy. There are some published reports of CNI avoidance altogether, where we would discontinue the CNI completely and then maintain patients on an mTOR inhibitor monotherapy in combination with their antimetabolite and corticosteroids. And then additionally, we could think always about adding on immunosuppression in the setting of recurrent or severe rejection, or things like chronic lung allograft dysfunction, where we would add on our mTOR inhibitor in addition to our standard maintenance triple immunosuppression regimen. For the purposes of this presentation today, I'm going to be focusing on the first strategy here, this calcineurin inhibitor minimization strategy. So looking at some of the data in thoracic transplant patients, there was a prospective open label randomized study done in 2012 that actually included both heart and lung transplant recipients with renal dysfunction. There were a total of 92 lung transplant recipients in this study, and their primary outcome, they were looking at whether or not a reduced dose CNI strategy with an mTOR inhibitor would result in improved renal outcomes for these patients. So to be included in these studies, these patients needed to have an eGFR of at least 20 to 90 mils per minute at the time of randomization and be at least 1 year from the time of transplant. At randomization, the patients were then either set to continue on their conventional calcineurin inhibitor-based regimen, or they were put on everolimus with a goal of 3 to 8, and then their calcineurin inhibitor dose was reduced by 30 to 70%, and their target goals for TAC were less than 4 and cyclosporin were less than 75. Regardless of the group, though, both groups were maintained on a cell cycle inhibitor and steroids as well. Looking at their baseline characteristics, the mean time from transplant overall was 52 months, and the mean eGFR at the time of randomization was 43 mils per minute. When we actually look at their calcineurin inhibitor levels throughout the time of the study, we can see that roughly both cyclosporin and tacrolimus levels decreased by about 50%. So if you look at the graph on the right-hand side of my screen, graph A, this is looking at mean cyclosporin concentrations, where the black line represents the everolimus cohort. So you can see throughout the 12 months after randomization, they targeted cyclosporin concentrations of about 53 in the everolimus cohort versus about 111 in the standard triple maintenance immunosuppression cohort. Similarly, in graph B on the bottom of my screen, we see they targeted mean TAC concentrations of about 4.4 in those who were also on everolimus, compared to TAC concentrations of about 8.7 in the control arm. So looking at their overall results for their primary outcome, which was change in eGFR from baseline at 12 months, they did see a significant improvement in eGFR of about 4.6 mils per minute in the everolimus arm, and they did see a decline in the control arm of about negative 0.5 mils per minute at 12 months. This was looking at heart and lung transplant recipients altogether, though. And when they divided it out to look at heart or lung transplant recipients alone, all this benefit in the eGFR was actually driven by the heart transplant group, and there was no significant difference in the lung transplant group at 12 months from randomization in eGFR. They then did a 2 and 5 year follow-up study of this, and the patients that were continued in their extension study, as seen in the graph A on the left-hand corner of my screen, you can see that in the lung transplant patients, actually at 24 months after randomization, there was a statistically significant difference where the patients in the everolimus reduced calcineurin inhibitor arm had an improvement in their eGFR from baseline, about 2.5 mils per minute, whereas the control arm had a continuous decrease in their eGFR at 24 months to about negative 3.5 mils per minute. When they further looked at the change in eGFR from baseline at the time of last follow-up, which was 5.6 years after lung transplantation, they had 38 patients that they had results for, and they did see that this benefit that they saw at the 24-month mark was actually lost at 5 years, and there is no difference in eGFR from the time of randomization between either arm. Looking more into the lung transplant patients specifically in this study, they did do some subgroup analyses to see who would be most likely to benefit from the mTOR reduced calcineurin inhibitor regimen. And they found that those who were closest to the time of transplant at randomization were more likely to benefit from an mTOR containing regimen. So those who were randomized between 12 and 28 months post-transplant had the highest increase in their eGFR compared to the controls. And you can see in the graph B on the left-hand side of my screen that those who were randomized greater than 56 months from the time of their transplant actually had no benefit at all. So this suggests that the earlier you can switch someone to this type of regimen, the more likely they are to benefit. Additionally, they also looked at whether or not eGFR at the time of randomization played a role in whether or not patients would benefit. And again, they found that patients who were below their median eGFR cutoff of 43 mils per minute were actually more likely to have a favorable renal response to the mTOR inhibitor containing regimen. Overall, over the course of 5 years, they did not see any difference in graft function, rejection, or death between the two groups. They did see more serious adverse events in the everolimus arm, and it was statistically significant. This was primarily driven by infections, pneumonias in the first 12 months. They did not see this persist in their follow-up extension studies at 24 months and 5 years. And they also saw increased edema and increases in lipid levels more common in the everolimus arm. So this study really suggested that potentially starting patients earlier to the time of their transplant, they may be more likely to benefit from this type of reduced calcineurin inhibitor and mTOR containing regimen. So subsequently in 2019, there was another prospective open label multi-center study that looked at whether or not early initiation of an mTOR inhibitor containing regimen would have a benefit on renal outcomes. So to be included in this study, adult lung transplant recipients who were at least 3 to 18 months post-transplant and had mild to moderate renal dysfunction were included. And they had to have been maintained on a calcineurin inhibitor, antimetabolite, and corticosteroid-based regimen. In this study, they excluded anyone with a BOS grade greater than 1, 2 or more episodes of AMR, 1 or more episode of ACR in the prior 3 months, as well as a urine protein excretion of greater than 1 gram per 24 hours. And then they were randomized to either a quadruple low CNI regimen, which was everolimus targeting a goal of 3 to 5, and then a calcineurin inhibitor with tacro levels running about 3 to 5 as well, or cyclosporin running about 25 to 75. The control arm was the standard triple maintenance immunosuppression regimen where they targeted tacrolimus goals of at least 5 or cyclosporin goals of at least 100, and then they were also maintained on a cell cycle inhibitor and corticosteroids. And the quadruple group with the mTOR, they were also maintained on a cell cycle inhibitor as well. So looking at their baseline characteristics, I have the results here presented as the quadruple low CNI versus the standard triple CNI regimen. There is no difference in the median time from transplant. The average time for the quadruple low CNI arm was about 10.6 months. And there was also no difference in eGFR at the time of randomization. Both groups were around 65 to 67 mLs per minute for their eGFR. So they actually had pretty good renal function coming into the study. Looking at their primary endpoint, which was change in eGFR at 12 months, they saw that the quadruple low CNI arm had a significant increase in their eGFR at 12 months of about 9.9 mils per minute compared to the standard triple maintenance immunosuppressive regimen. And as you can see in this graph on the right, you actually started to see the difference in their renal function by about 1 month after randomization. So the everolimus arm, which is represented in these white boxes here, they saw their eGFR actually increase, and then this persisted throughout the first 12 months from randomization. When they then stratified them further, looking at baseline eGFR, they found that those who were most likely to benefit from a renal perspective were those with a baseline eGFR between 40 and 60. And those patients actually had an increase in their eGFR of about 15 mils per minute. When looking at higher eGFRs, when we get to the eGFRs of 76 to 100, they actually did not see a statistically significant difference between the groups. Looking at their secondary endpoints for efficacy, they found no difference in rejection between the groups, no difference in incidence of CLAD, death, or infection. They did see more adverse events in the everolimus arm, where 25% of the patients had to discontinue the therapy due to side effects. And this was primarily driven by more peripheral edema and acne in the quadruple group. They did not see any new cases of proteinuria in the quadruple group and no difference in proteinuria between either of the groups. So overall, this study was really promising in that it showed early conversion to an mTOR inhibitor containing regimen, resulted in improved renal function compared to our standard triple maintenance immunosuppressive regimen while maintaining therapeutic efficacy. And then finally, I just want to touch a little bit on proteinuria and renal response. So this has been looked at in some other organ transplant populations as well, but this particular study was looking to see if there are any predictors of who would respond from a renal perspective when putting them on an mTOR inhibitor based regimen. So this was a retrospective study of 56 lung transplant recipients who had an eGFR less than 60 who were converted to a sirolimus-based regimen. 10 of these patients were on a CNI-free regimen altogether, and then the remainder of the patients were on a reduced calcineurin inhibitor-based regimen in addition to sirolimus. So looking at the renal response from the time of conversion, altogether, they found positive results. There was an increase in eGFR of about 8 mils per minute by 1 month post-conversion, and this persisted until 18 months of follow-up. Interestingly, when they did their analysis, though, looking at predictors of renal response, they found that those who had proteinuria at baseline were less likely to have an increase in their eGFR. So you can see here in this figure 4 on the right, the open squares is the absence of proteinuria. And you can see from conversion to 1 month, these patients were much more likely to respond from an eGFR standpoint compared to patients who did have proteinuria at baseline. So overall, these authors concluded that the absence of proteinuria at the time of conversion was independently predictive of a favorable renal response. So I'm going to now turn it over back to Spencer to talk about early initiation of belatacept.
All right, thank you. So we're going to spend the next few slides walking through the recently published study looking at using belatacept de novo in our lung transplant population. The hypothesis behind why this study was attempted was given the kidney literature that was suggestive of a decreased risk of DSA in belatacept treated patients when compared to CNI treated patients was really intriguing because, DSA is harmful in any organ, but especially so in lung transplant, given the direct link to development of CLAD, which is then also directly linked to morbidity and mortality. This was a pilot phase 2 study. It was open label at 2 transplant centers, including my own. And this kind of goal of the study was to assess feasibility for a phase 3 study. The dosing schematic is listed below. These patients were given induction immunosuppression with thymo, and then they were started on the standard of care tacrolimus, mycophenolate, and prednisone, or they were in the investigational arm where they received belatacept, tacrolimus, and prednisone. And at month 3 post-transplant, the tacrolimus was swapped for mycophenolate. The trough goal for tacrolimus was 8 to 15. If we had normal renal function, in patients with impaired renal function, this was decreased to 4 to 8. The study took place from January of 2020 to May of 2021 and ultimately randomized 27 patients, pretty evenly split between belatacept and control. However, in May of 2021, death number 3 in the belatacept arm occurred compared to no deaths within the standard of care arm. And because of this, the study was stopped and patients that were in belatacept or receiving belatacept were converted to standard of care. In the 8 weeks that followed that, there were 2 additional deaths, which led to a percentage of 38% death in the belatacept arm compared to none in the control arm, which was statistically significant. The causes of death really widely varied though. So we had the first 3 deaths occurred while receiving belatacept due to COVID-19 infection, restrictive allograft syndrome following a rhinoenterovirus infection, and a hemothorax. And then the subsequent 2 deaths that occurred after they were converted to standard of care was due to a fatal PE and PTLD. And I do want to point out here that with the COVID-19 death, this was pre-Evusheld, and it's not clear if the patient was vaccinated. The authors state that there was no difference in the development of DSA, including the class of DSA and C1q positive DSA. There was also no difference in incidence or grading of cellular rejections and no difference in infections. This study did not assess renal function. And so really the takeaways from this pilot trial was that early use of belatacept after lung transplant was associated with increased mortality. However, the causes of death really widely varied, and so it's really unclear which mechanism by which belatacept would have contributed to all of those different types of death. It was also a small sample size, so we do have an increased risk of error, and it was unable to assess long-term outcomes such as chronic rejection or survival. And given that those patients that were originally receiving belatacept were converted to standard of care, it's unlikely that those long-term outcomes will ever be accessible in any meaningful way. All right, I'm going to switch gears now and talk about adverse effects. And this is going to start with adverse effects related to the lung function and then mainly infections after this. The adverse safety reports with lung function really are only 2 different case reports. However, we should keep in mind that the case series describing the use of belatacept for renal sparing purposes only added up to like 17 patients. And so when we look at these 2 case reports, we firstly have a 65-year-old single lung transplant recipient who was switched from tacrolimus 11 months after transplant for CKD. 27 days after their first infusion of belatacept, they did develop ARDS requiring hospitalization and intubation. Their biopsy showed positive CD8 cells and no DSA, and they received methylprednisolone boluses. Ultimately, this patient died due to sepsis at day 54 after conversion. However, the authors state that they believe that ACR grade A4 was implicated in the ARDS development. The second case report is a 50-year-old who was transitioned to belatacept from tacrolimus 2 years after lung transplant, again for CKD. They had progressive lung function decline starting a couple of months after the first belatacept infusion. They obtained a biopsy, which was negative, and DSA was also found to be negative. However, their lung function did not improve. And because of that, they biopsied again, which was again clean. They also rolled out DSA once more, and they also rolled out PTLD. However, 1 week after that second biopsy, really no improvement in lung function. So they did a wedge resection, and that tissue had A4, B2 rejection. The patient received thymo for this rejection, and the author stated that at last follow-up, their FEV1 was about 36% of their personal best. Next, we're going to talk about infections. I think infections are, a concern with any of the solid organ transplants. However, especially so with lung transplant, given the constant communication with the outside environment and the direct link between infections and development of CLAD and therefore morbidity and mortality. The ID data is mainly coming out of the kidney transplant population at this point, so that's going to be what I'm going to be reviewing over the next couple of slides. Going to start with CMV. There was a French study that compared patients who had converted to belatacept to calcineurin inhibitor treated patients, and they propensity matched based on age, the time from transplant, the year of their transplant, induction immunosuppression received, CMV serostatus, and renal biopsy scores. They had to be on belatacept for at least 6 months to be included in this study. And despite no differences in rejection treatment received or in CMV prophylaxis, they did find a significantly higher rate of CMV disease in the belatacept treated patients, almost 18% when compared to CNI treated patients. Most of those CMV diseases initially presented as tissue invasive CMV. These patients mainly converted an average of a year from transplant, so it's possible that they were not undergoing routine surveillance of CMV at that time, so potentially it just wasn't caught until later. They did a multivariable analysis to try and identify risk factors for CMV on belatacept, and they identified high-risk serostatus, an older age at conversion, which was later pinpointed to be 70 years or older, and lower GFR at conversion, which they later pinpointed to be less than 30 mils per minute, as being risk factors for CMV disease. In this study, they also identified that over time, the incidence of CMV decreased in the CNI arm, but increased in the belatacept arm. Furthermore, they found that in the belatacept treated patients that developed CMV, after their initial resolution, about 37% of them had either sustained CMV DNA anemia or recurrent CMV infection. The next study was a US study that compared seronegative kidney transplant recipients, and these were de novo treated patients. They really had two different comparisons going on here. So they were comparing CMV high risk versus low risk, and they were also comparing belatacept to tacrolimus. And what they found was that belatacept patients who were CMV high risk were more likely to develop CMV DNA anemia in the first 2 years, significantly so. They also found that those patients that did develop CMV had a longer time to clear that, and they also had higher rates of vancyclovir resistance. There was no difference in the peak viral load or in graft outcomes. And taking a step back from CMV and looking at infections overall, a couple of studies I wanted to highlight here. The first one was a single center study comparing conversion to belatacept patients to tacrolimus treated patients in the kidney transplant population. And what they found was that belatacept had significantly higher infections when compared to tacrolimus, 42% versus about 30%. When they stratified this by infection type, they found that the only thing that was significantly different between the groups was bacterial pneumonia requiring hospitalization. However, they found numerically higher rates of PJP and pyelonephritis in the belatacept treated patients. It also should be noted that the average age in both arms was 52 years, which was less than that year of 70 that we found as the cutoff for increased risk of CMV in the previous study. One other really interesting thing that they found was that the risk for infection seemed to be really centered around the ones that were converted early after transplant. If patients were converted more than 6 months after transplant, they actually had no difference in the rates of opportunistic infections. The next study was descriptive only, but it was multi-center and 280 kidney transplant recipients. And it had a lot of really good information in this article. So I'm just going to call out a few things here, which is that they found CMV disease rate was high at about 43%. And they found that PJP occurred in greater than a quarter of patients. It should be noted, though, that none of the patients who developed CMV were on prophylaxis, and none of the patients who developed PJP were on prophylaxis. Similar to the previous studies, they found that most of the presentations of CMV on belatacept were tissue invasive. They also found a very similar finding, which is that if they were converted less than 6 months, they were at higher risk for infection. But in the patients that were converted greater than 6 months from transplant, their infection risk seemed to be mitigated. And lastly, there's just really one case report of an infectious complication post-lung transplant. So this patient was converted to belatacept about 3 years after transplant. And within a couple of weeks of receiving that first infusion, they developed invasive aspergillus. So my takeaways when we look at belatacept overall in the lung transplant population is that we do have a clear signal that there could be benefit in using belatacept when we think about renal sparing. It was described in 2 case series that GFR improved in lung transplant patients who were converted. So if we're just kind of assessing GFR alone and CKD alone, I think that it's a great option. However, I think some of the safety signals make me a little bit concerned about using this in the lung transplant population. There's conflicting data regarding safety. So if we kind of count out all of the lung transplant patients on belatacept that have been published, I counted about 25 patients. 15 of those reported safe use with no DSA or rejection and stable lung function. However, there were also 10 reports of unsafe use, including increased BOS staging, A4-ACR, and death. There's also clearly a signal that there's higher rates of infection with belatacept when we compare it to calcineurin inhibitors, especially as it pertains to CMV and PJP. So if we were to put a lung transplant patient on belatacept, I think that I would want to have serial monitoring of CMV PCRs, and then also make sure that our patients are on lifelong PJP prophylaxis. All right, I'll turn it back over to Krista.
All right, thank you, Spencer. So I'm sure we're all familiar with the adverse effects of mTOR inhibitors. I think this picture on the right here summarizes it nicely in that virtually every organ system is affected by the mTOR inhibitor pathway. So it leads to a variety of adverse effects. The one thing I want to point out with these is that they are dose dependent, and a lot of the earlier trials that were done, they targeted really high sirolimus and everolimus levels, and that's why we saw such a high rate of drug discontinuation due to adverse effects. So targeting lower mTOR inhibitor levels in combination with a lower CNI level really gives us a little bit more control about some of these side effects, but some of them can still occur, so it's good for us to be mindful of them. Some of the most bothersome ones for patients are the mouth or oral ulcerations and mucositis that can happen, as well as the peripheral or lymphedema that can happen and be really bothersome to patients. In our lung transplant patients in particular, particularly those who are close to the time of their transplant, there is an increased risk of thromboembolic disease such as DVT or PE that has been seen in prospective trials with mTOR inhibitors. They do still affect our counts, and we can get cytopenias with them as well. And then from a renal perspective, really the big one is the development of proteinuria, which is kind of hard in our CKD patients because many of these patients already have some degree of proteinuria baseline. So it's really important to be monitoring for this one in particular to make sure that we're not worsening their renal function in the long term by putting them on an mTOR inhibitor. And then there have been reports of mTOR inhibitors causing drug-induced pneumonitis or interstitial lung disease that is usually reversible upon drug discontinuation. And then we do have a variety of endocrine and cardiovascular effects, most notably the dyslipidemias that can occur, particularly the high triglyceride levels that we can see in patients on mTOR inhibitors. So looking at all these, there's a few things I would definitely avoid use of mTOR inhibitors in anyone really close to surgery or with an upcoming surgery where they have ongoing wound healing concerns. I would wait to start. If we are thinking about initiating it in someone and they already have severe proteinuria or severe dyslipidemias at baseline, we know the mTOR inhibitor is just definitely going to worsen that. So that may also be someone who wouldn't be a good candidate when evaluating them from a side effect standpoint. All right, now looking at some key takeaways from the mTOR inhibitors, it's really kind of a pro-con debate itself with the mTOR inhibitors when you think about whether or not you want to use it. So from some of the data I showed you, timing is really key. It's really should be used in more of a proactive approach from a renal function standpoint, not waiting till someone has stage 4 CKD to start thinking about whether it's a good time to reduce their calcineurin inhibitor exposure. So kind of assessing patients and looking at their trends in their renal function, because we do see most of the benefit occur when patients have an eGFR of around 40 to 60. So if we can be proactive in terms of recommending or considering use for these, that'd probably be best from a CKD standpoint. And then additionally, I usually try and see like how many birds I can kill with one stone with an mTOR inhibitor. We know there's so many different indications that we can use them for. So not only from a CKD perspective, but looking at whether or not they have any other indications, such as a history of skin cancer, a history of significant CMV disease. If they're unable to tolerate their standard immunosuppression regimen at baseline, such as their CNI or MMF, it might be a good substitution. Or if they have recurrent rejection or early onset CLAD, that'd be another place in therapy for mTOR inhibitors, where not only we could help possibly mitigate the nephrotoxic effects of CNI inhibitors by adding on an mTOR inhibitor, but also help with some of these other indications. And then similar to what I said before, just evaluating what are the reasons why we shouldn't be using an mTOR inhibitor in some of these patients, and making that risk assessment and having that conversation before we start them. And then importantly, I think it's really important to assess the response on their renal function. In both of those trials I showed you, they actually had a pretty quick response. Most of the people seem to have a response within a month of starting therapy. So definitely take a look and make sure we're following up on their renal function 1 to 3 months after starting the mTOR inhibitor to see if it's benefiting them at that point in time. And then of course, given the slew of side effects with these drugs, it's really important to keep a close eye on monitoring for them as they stay on therapy. All right. So I think we're ready to go into the cases.
Yeah, thank you so much for that excellent background, Dr. January and Dr. Walter. That was a great case, great discussion. However, in lung transplant, we all know there is no straightforward patient. So we're going to apply some of the things that we've reviewed to some specific patient cases. The first one, talking about a 66-year-old male with IPF who is 6 months post-lung transplant with serologies of CMV positive to negative and EBV positive to positive, who you're seeing in clinic after they've had a very complicated post-operative course. After several operative complications requiring repeat ORs to manage post-operative bleeding, as well as renal replacement therapy for the first 2 weeks after the patient's transplant. The patient has noted some renal recovery and was able to transition off renal replacement therapy 2 weeks post-operatively, but has since lived with a baseline creatinine around 2, which for this patient correlates to an eGFR of about 35, though no proteinuria is currently present. Since leaving the rehab facility 2 months ago, the patient has not experienced any further complications and has a current immunosuppression regimen of tacrolimus with a goal of 10 to 13, mycophenolate mofetil, 1 gram twice daily, prednisone of 15 milligrams daily, as well as stable PFTs, which are noted to the right. So starting with Dr. January, can you walk us through and see if we can optimize immunosuppression to prevent any further chronic kidney disease development?
All right. So for this patient, I do think that he could be a good candidate for conversion to belatacept. The pros for this patient is that he is elderly at 66. And so therefore we do have probably some immune senescence occurring. He also has a lack of significant rejection history, and he does have stable lung function. So I think from an immunological risk standpoint of rejection, he's pretty low risk. And therefore, I think that my concern for a severe ACR that we saw in a couple of those cases would be pretty small. And we do see benefit in those two case series in improving his GFR potentially. And really the main con centers around CMV in this patient. So he has CMV high risk. We do have very consistent literature out of the kidney population demonstrating an increased risk for CMV, DNA and disease. He also approaches that 70 years old cutoff that was identified in that first CMV study as being increased risk for CMV. However, I think that potentially we could mitigate this risk by having serial monitoring of CMV PCRs so that we could catch it and treat it pretty soon if it were to develop. However, in this particular patient, I think we have another potentially safer option, which is firstly to lower that tacrolimus trough goal, since we know that that is directly linked to renal dysfunction. My recommendation would be to lower that from 10 to 13 to closer to the 4 to 7 range. We can continue to monitor his GFRs, and if they really don't improve or worsen after a few months, if we assume that the patient is EBV seropositive, then we could consider conversion to belatacept. But again, I would want to make sure that we are serially monitoring the CMV PCRs and making sure that the patient is maintained on lifelong PJP prophylaxis.
Okay, so I'll make my case for the mTOR inhibitor. So this patient, looking at them from just a renal standpoint alone, it is somewhat ideal timing in that his eGFR is already around 35. If we sit around and watch and wait much longer, you know, there's a potential for the eGFR to decline further with added CNI toxicity. Right now, he probably doesn't have irreversible CNI nephrotoxicity, given that he's only 6 months out from transplant. And then there's no proteinuria present, so he is likely to respond from a renal perspective, adding on an mTOR inhibitor. We also know that it's likely comparable from a rejection standpoint to our standard triple maintenance immunosuppression. This patient doesn't have any current history of rejection that makes me concerned he's particularly high immunologic risk. And then, as presented earlier, he is CMV high risk. And while we do prophylax against that, if he were to develop CMV infection, having an mTOR inhibitor on board may actually be beneficial from a CMV infection standpoint. Looking at some cons. So based on this case, the renal dysfunction that this patient presents with is likely multifactorial. I don't think we can blame all this renal dysfunction on the CNI at this standpoint. They had a really complicated postoperative course that's likely playing a role into the degree of renal dysfunction present. And additionally, this patient's 6 months out from transplant, so CNI levels should already be starting to decrease soon, assuming this patient has not had any rejection. So it is possible with reduced CNI exposure that we're already planning on doing, he may have some improvement in renal function. My main concern with this case was all the postoperative bleeding that this patient had. I would definitely want to make sure with the surgery team that there's no further concerns for any bleeding, no plans for going back into the OR, and no concerns for wound healing in this patient at this time before starting an mTOR inhibitor. Additionally, with this patient only being 6 months out from transplant, we know there's a heightened thrombosis risk, and this risk is even further heightened when adding on an mTOR inhibitor. We're also adding on another drug to this patient's regimen. So with that comes that long list of side effects I mentioned before. So whether or not this patient will be able to tolerate another agent. And then depending on the center, this patient may still be on antifungals. So that will create another set of problems with drug interactions that we can of course manage, but something to be mindful of. And then the other potential con, and I put this as a question mark, is the impact on DSA formation. In the lung transplant literature, it's somewhat unknown whether reducing CNI goals this early post-transplant and adding on an mTOR would have an impact on DSA formation or not. So for my recommendations, it's kind of twofold. So we could watch and wait, and I put that with a small caveat that I don't want to wait too long. So potentially decreasing the tacrolimus goal, seeing how that patient does for 1 to 2 months on a lower goal. And then if they don't really respond from a renal perspective, you could employ that quadruple base therapy from that trial that I presented earlier, where we start an mTOR inhibitor and reduce the tacrolimus goal to about 4 to 6, continue with the antimetabolite and steroid taper as is currently, and then monitoring for side effects and tolerance. Sorry, just one other comment. And briefly, the TAC and everolimus goals, I know those were different than the trial that I presented, but in general, I kind of cut them in half from what the patient's immunosuppression was currently running at.
Great. Thank you both for your commentary on it. I think certainly reducing that CNIGL might be a good first line option, but great to start planting the seed and start thinking about perhaps insurance coverage or tolerance, and things might push us one way or the other. For your second case, younger patient population, who in clinic, you're seeing a 33-year-old female transplant who is 2 years post-transplantation for cystic fibrosis. The patient has noticed an increase in creatinine in the past 5 months from a baseline of around 1 to a current baseline of 1.6, which for this patient correlates to a GFR of 48. No proteinuria currently present. The patient has a history of Pseudomonas colonization, with the last treated infection being 2 months prior, and Aspergillus noted pre-transplant with no recurrence post-transplant. The patient has struggled with some adherence and had 2 cases of A2 secondary to high variability in tacrolimus levels, but this was last treated 6 months prior and is no longer on an azole antifungal therapy. Current immunosuppression regimen is listed below with tacrolimus 8 to 10, mycophenolate mofetil 1 gram BID, and prednisone 5 milligrams daily. And noted to the right, you can see a decline in her PFTs recently. So again, starting with Dr. January, can you please discuss how you would optimize her immunosuppression to prevent further chronic kidney disease development?
I actually think that Krista is going to kick this one off.
Thank you.
Yes. So looking at this case from the mTOR inhibitor lens, from a renal function standpoint, I do think this is a really good time to start talking about this. 1, she doesn't have any proteinuria present, and 2, her eGFR is within that window of the 40 to 60 where we typically see the most benefit. So I actually think starting an mTOR now or lowering that CNI exposure could be really beneficial long-term for this patient. Additionally, she's very young as well. She is a little farther out from transplant, but she's still within that 5-year window of transplant where we can still potentially see benefit from a CKD perspective and renal response perspective. And then looking at her PFTs, so Georgina mentioned they did go down recently. I'm going to assume for this case that we have ruled out other causes such as infection or rejection at this time. And if we do rule those out, this patient actually would meet criteria for CLAD stage 1 based on her drop in FEV1 from baseline. And she does have an obstructive pattern that does make it suggestive of BOS. So there is some data to show that early initiation of mTOR inhibitors in early stages of BOS may be actually protective in terms of reducing the fibroblast proliferation that may play a role in that disease state. Additionally, it's kind of another layer of immunosuppression, so we're intensifying her immunosuppression a little bit. She does have the history of recurrent rejection, so I think from a rejection standpoint, it is safe. And then I don't see a reason why we couldn't use it in her at this time. My main concern with using an mTOR inhibitor in her is she's already had documented adherence concerns and rejection secondary to variability in her tacro levels. So adding another medication that also needs therapeutic drug monitoring is going to further increase her medication complexity. But on the bright side, we can still monitor the levels, so we'll know if she's taking it. And then the other con is the infection risk. She has a history significant for Pseudomonas pneumonias. So we do have to balance that by adding on another agent. So overall, my recommendations for her would be to start everolimus, targeting a goal of 3 to 8, and then reduce her TAC to 4 to 6. I was thinking of reducing her MMF by at least 50% to start and then see how she does. She does okay. You could potentially discontinue that altogether, and then continue her current steroid dose as is. Since she is cystic fibrosis, she may actually require higher starting doses of everolimus. Another alternative you could consider for her would be sirolimus as a once daily option. I'm not sure if that would make it easier from an adherence perspective since she's already on BID other medications, but something to consider. And then again, reassessing the benefit on both her renal and her lung function soon after initiation to see if she is even benefiting from it.
All right, and from the belatacept standpoint, there's a few potential pros. Potentially, it could improve adherence. I think that was a big selling point when it hit the market. However, one missed dose of belatacept would be more problematic, most likely, than one missed dose of tacrolimus. It also could help stabilize the GFR based on those two very small case series that we saw, and there would be less drug interactions when compared to tacrolimus or an mTOR inhibitor. I know she's off of the azole antifungal right now, but if we have recurrence of that aspergillus and she goes back on it, then it could minimize that drug interaction. However, there's a lot of cons in this patient being on belatacept. I think that we do have a potential signal that there's higher rejection risk based on those two case reports of A4-ACR in a patient who already has issues with rejection. And we know that every rejection episodes puts our patient at increased risk of developing CLAD and therefore limiting graft survival, which is terrible in any patient, but especially a very young patient. There's also a higher infection risk with belatacept in a patient with a significant infection history, especially from that one kidney study looking at rates of bacterial pneumonia requiring hospitalization. If she's not adherent to medications, I would be concerned that she also was not adherent to labs, which would limit our ability to serially monitor CMV PCRs. So I think overall, she's really too high risk to be considered for conversion to belatacept. So I do think that we could consider decreasing the tacrolimus goal, plus or minus adding on an mTOR inhibitor.
Thank you all for those debate on either side. I did want to open it up for any questions. I know we're right at the end of the hour, so if you have any questions, please put them in the chat at this time. And I might start us off with a question for Krista, which will be, you talked about, kind of the pros and cons of everolimus versus sirolimus for the second patient in terms of adherence, but in your experience, do you have a preference for one over the other? And what's your threshold when you're managing adverse effects to switch from one to the other or just discontinue therapy altogether?
Yeah, I think in the lung transplant population, my preference has been to go with everolimus. And I've just seen, there just seems to be a little bit more data with everolimus in that patient population. So that has been my preference for starting someone. I think the side effects are pretty much a class effect. There is some reports that maybe with sirolimus, you see a little bit more side effects, but it's hard to really interpret those because a lot of the trials with sirolimus, since it came out earlier, they were targeting really, really high levels. So it's really hard to kind of tease out how much of those side effects we actually see when targeting sort of more reasonable levels of sirolimus. So if someone's really having bothersome adverse effects from the mTOR inhibitor, like peripheral edema or the mouth ulcers or things like that, that's impairing their quality of life, I'd probably advocate to just stop it versus just switching. And then my threshold to DC altogether would really be looking at their trends. So really from a renal function perspective, if they've already got some proteinuria at baseline and we start them on an mTOR inhibitor, and we don't keep a close eye on it and their proteinuria significantly worsens, we're probably going to expedite the degree of their renal dysfunction and potential to go to renal failure. So if I see, significant increases in the proteinuria that's not responsive to treatment with like RAS inhibition, I would advocate for stopping it as well. And then same thing with like the cholesterol and dyslipidemias. We know our CKD patients are already at high cardiovascular risk. So if they're having issues with that are putting them at even higher cardiovascular risk that we can't treat with other therapies, I would advocate for stopping it.
Great, thank you. Agree. And then Dr. January, this is a, in coverage perspective on belatacept. Certainly the data you shared was not necessarily cheerleading for in our lung transplant population, but when you have had to use it, can you talk about how you get this medication covered and infusion?
Sure. I've actually had pretty limited firsthand experience with insurance coverage for belatacept outside of the renal transplant population. The de novo trial that occurred at my center was all ran through the investigational services, so insurance approval was not required. I'm also a little bit spoiled because our nurse coordinators take care of all of the insurance and infusion center logistics. But it is a really important question. So I'm really curious if anyone in the audience has experience with getting belatacept approved in the lung transplant arena.
I can certainly start and say that it took us
Oh no, I think we might have lost Regina. Yeah.
Does anyone else have any insight into getting it approved for lung transplant?
Oh, she's back.
Yes, I was about to say, if there was a time for my internet to go down, it was right at the end of the presentation. So I personally had struggled for a year to get a patient covered for belatacept, and this was in the heart transplant population, but one of the things we really did struggle was setting up an infusion center because this patient lived in Albany, New York. It's quite far for us in the Boston area. So there were certainly a lot of barriers we had to overcome, but recently there was quite a great presentation on kind of the logistics of belatacept as well, I think that ACCP put on. With that, any other questions? Okay, I hear from Lauren. She said, we haven't had any issues except for those who live out of state in rural areas. That's great to hear. And I think those rural populations are, outside of your network can be some of the ones that are more difficult to identify and support. Well, seeing no other questions, I would like to thank our presenters, and we will conclude the webinar today. Thank you so much for your time and joining us. And please feel free to reach out if you have any other questions to either presenters. Thank you so much.